All right. In this lecture, it'll be pretty quick. We're going to talk about brucellosis. So this is a commonly tested zoonotic infection. Maybe you've come across it in step 1 and step 2 studying. If not, it'll be something new to learn. It's relatively low yield, but I have seen zoonotic infections show up on both my step 1, step 2 exams and on practice tests. So it's definitely fair game. It might be like a question or two. I'll kind of touch on other zoonotic infections kind of as lectures come here or there. But Brucella is definitely a big one to know. This will be a relatively quick one because we're just going to cover this one and then be done. So we're going to understand the pathogenesis and epidemiology of brucellosis. We'll discuss the management strategies and then we'll put it all together. All right, so our case to consider. So I put this on Instagram the other day. Actually, a lot of people got it right, so I was pretty surprised. Brucella, reading a vignette and figuring out it's Brucella, maybe not as hard, but knowing the management, that was the hard part of this question, and a lot of people got it, so that was good. So people are doing their studying. So we have a 32-year-old man presents with a 2-week history of intermittent fever, night sweats, malaise, and arthralgias. He recently returned from a trip to rural Mexico where he consumed unpasteurized goat cheese. On exam, his temp is 38.5, and he has mild hepatosplenomegaly. Lab studies reveal mild anemia and elevated transaminases. Blood cultures are pending. Which of the following is the most appropriate next step in management? Should we start empiric doxy and rifampin? Should we order a TB skin test? Should we begin corticosteroid therapy? Or should we start empiric ceftriaxone monotherapy? So pause your screen and think about it. So in this case, right, we have a relatively younger man. He's got this 2 weeks of fever, right? He's got night sweats, malaise, arthralgias. Definitely could be pointing me towards TB, especially because he was in rural Mexico. So maybe that's pointing me towards TB. What is kind of throwing me more towards brucellosis, right? Because brucellosis can absolutely show up the exact same way. It's this unpasteurized goat cheese, okay? We'll talk about why that's important, but that points me more towards maybe a zoonotic infection like Brucella, especially Brucella in this case. The other things that point me more towards it, right? The hepatosplenomegaly is pretty classic for Brucella. Don't get me wrong, TB can absolutely cause hepatosplenomegaly when it becomes miliary TB. Okay. We also see the mild anemia and elevated transaminases. Again, if TB gets to the liver, it can cause elevated transaminases. The anemia with TB would be more rare, but also the patient could have anemia of inflammation or anemia of chronic disease, if you will, which could cause mild anemia. But really, what's pointing me towards this man has traveled to a place where Brucella is very common. We'll talk about that in a second. And he has a very big risk factor for unpasteurized goat cheese. Now, I really hate standardized exam questions because when this patient presents to my emergency department or he comes up to the wards on IM and I'm taking care of him, if he hasn't gotten a TB test, we'll probably get a TB test. Absolutely, right? But really, what the board exam questions are demanding of you is you can only choose one thing. Obviously, in real life, we do more than one thing. If we can only choose one thing, this is really pointing me more towards brucellosis. Let's start empiric doxy and rifampin. Okay, that's going to be the best answer. So doxy and rifampin are the associated, the gold standard treatment for brucellosis. We are going to probably need to get blood cultures, right, to confirm the diagnosis. But once we get blood, we can start the empiric therapy. Corticosteroids are not indicated. Ceftriaxone monotherapy is not recommended. And then TB skin test is not really relevant based on the unpasteurized goat cheese. We probably would get the TB test, but it's not going to be the best next best step. So let's talk about brucellosis. It's caused by the Brucella species, which is a gram-negative intracellular coccobacilli. So I've seen other questions where they describe a patient with the fever, night sweats, arthralgias, hepatosplenomegaly, anemia. They ate goat cheese, unpasteurized goat cheese, raw milk. They were around livestock X, Y, or Z. And instead of asking you what's the diagnosis, what's the treatment, they give you all a bunch, like 5 different options of bug, like pathogen descriptions, right? And you're going to look for the gram-negative intracellular coccobacilli. The most virulent of the species is Brucella militensis, which are found in goats and sheep. Okay, that's probably lower yield. Just think Brucella in general. How do we get it? Ingestion of unpasteurized dairy. So we saw goat cheese here. Contact with infected animals or animal products. okay? And it's endemic in rural Mexico, Middle East, and Mediterranean, right? So this patient was in rural Mexico and he had unpasteurized goat cheese, two very, very big risk factors for transmission. What's the presentation? They can have intermittent fever and night sweats. The night sweats are often described as a wet hay odor. They probably won't give you that in the vignette. That's very buzzwordy. But maybe if you're ever seeing a real patient in real life and you're trying to get to it, you can ask them what those night sweats have any scent to them. They have malaise, fatigue, arthralgias, myalgias, again, really non-specific systemic problems here. And they may have hepatosplenomegaly and elevated LFTs. On labs, we could see mild anemia and transaminitis. Brucella can also cause hemolytic anemia. So we can see elevated LDH, indirect bili, and low haptoglobin. I talk about that in my MAHA lecture. Really, though, me seeing mild anemia, transaminitis, and some of these other non-specific things that, like, I'm like, wow, this could be like a million things. We need to have a high suspicion based on travel and food exposure. Some complications are osteoarticular disease. So they're very, very common. So the arthralgias, and then especially in the lower lumbar spine area, we can often get some damage there. So arthritis and spondylitis, and then this can become chronic or relapsing if untreated. The incubation is usually 2 to 4 weeks, but it can range up to several months. So the patient may have traveled like a month ago and now is starting to find symptoms. Brucellosis shows up in some of my schemas that I've talked about some of them. I haven't talked about the full hemolytic anemia schema yet. But when I think about Brucella falls into my fever of unknown origin schema, and it falls into my hemolytic anemia schema, okay? I did a whole lecture on fever of unknown origin. Remember, I can split those up into infectious, non-infectious inflammatory disease, malignant, and other. When I think about my infectious causes of fever of unknown origin, I think about zoonotic infection, viral infection, occult abscess, endocarditis, vertebral osteomyelitis, and TB, right? So zoonotic infection, Brucella would fall. And if we go back to my case, right, he's got this 2-week history of intermittent fever, right? He hasn't quite met the definition for fever of unknown origin yet. But really, at this point, if he's had 2 weeks of fever, I can consider that a fever of unknown origin. We got to work it up. So I would put that. Now I'm thinking fever of unknown origin. I can start thinking about my schema, right? What does he fit? He fits a zoonotic infection. Also, if this patient showed up with hemolytic anemia labs, right, I can split up hemolytic anemia into inherited and acquired. And so inherited causes of hemolytic anemia would be, in big buckets, would be hemoglobin problems, enzyme problems, and membrane problems. And then in the acquired side, we have immunological, toxic, traumatic, and then infectious causes, right? And so this would be infectious. And some of my causes of infectious hemolytic anemia would be like Clostridium perfringens, babesiosis, malaria. We have Brucellosis, Bartonella, and then those are going to be like some of the big ones. Like Mycoplasma also comes to mind, would be some of the more prominent. And then Haemophilus is also another one that comes to mind as well. So those are the 7, right? I do have in my schema, it's 7 different causes of infectious hemolytic anemia. I've now named all 7. Sometimes it just takes a little bit, right? There's a lot to consider. So whenever I see hemolytic anemia and I'm thinking about an infectious cause, Brucella is one of them that comes to mind. When I'm thinking about fever of unknown origin and I'm leaning more towards an infectious cause, zoonotic infection comes to mind. So that's how Brucella comes to mind when I'm working up patients. So diagnosis and treatment, serology, we most commonly use the serum agglutination test. It's the most common diagnostic method. We can do blood cultures, but that will take several days to grow. The sensitivity will decrease in chronic cases. So again, if we have a strong suspicion, we're going to start that doxyrifampin. Bone marrow cultures are higher yield, especially in the chronic disease. We can do PCR and ELISA, and then we can consider imaging like MRI for focal complications if they have spondylitis. The treatment based on WHO and CDC recommendations for uncomplicated brucellosis, we'll do doxy for 6 weeks and rifampin for 6 weeks. Alternative, we can do doxycycline for 6 weeks plus streptomycin and aminoglycoside for 2 to 3 weeks. If we have focal disease like endocarditis or neurobrucellosis, we can add an aminoglycoside or a third agent like ceftriaxone, and that's going to be a long treatment. Remember, brucellosis or brucella is a cause of endogram or like negative endocarditis, culture negative endocarditis, where we draw blood cultures. We take 3 blood cultures. we don't see anything, right? It's a common cause of culture negative endocarditis. So it's one we do need to look out for. Relapse is common without adequate duration in combo therapy. If you want to read more, here's the CDC Yellow Book and then another study I used to pull from it. But really, brucellosis, right? I'm thinking about a patient who traveled to rural Mexico, the Mediterranean, right, is another common area. They're in some sort of contact with farm animals or some sort of unpasteurized goat cheese, unpasteurized dairy, or infected meat of some sort, right? We're going to look for fever, night sweats, myalgias, arthralgias. They could have anemia. It could be hemolytic in nature. They could have transaminitis. Okay. We're going to get a serology and blood cultures are going to be the go-to. We're going to start doxy and rifampin for 6 weeks each, right? And then we can adjust from there. That's how I think about brucellosis. Again, it's in my fever of unknown origin and hemolytic anemia schemas that I think about. So let's put it all together. We have a 45-year-old male rancher presents to the clinic with 6 weeks of fatigue, intermittent low-grade fever, and worsening low back pain. He describes the back pain as dull and worse at night, with morning stiffness lasting over an hour. He also reports night sweats and poor appetite. He denies cough, weight loss, or recent travel outside the U.S., but mentions he visited family in rural northern Mexico 3 months ago and consumed fresh goat cheese. On exam, he has mild tenderness over the lumbar spine, but no focal neurological deficits. There is no joint swelling. His ESR is elevated. The CRP is elevated. The white blood cell count's normal. He's got mild anemia here, mild transaminitis. ANA and rheumatoid factor are negative. The TB skin test is negative. The MRI lumbar spine shows spondylodiscitis at L4, L5 with adjacent vertebral edema. His blood cultures are pending. So with all this, right, we're experts in brucellosis now. We prescribe him 6 weeks of doxy and rifampin while we're waiting for those blood cultures. Our attending tells us that doxy is an oral option for outpatient MRSA management as well. He asks you to name 3 other antibiotics that can be used for outpatient MRSA management. So my question for you is, can you name 3 other antibiotics that are used for outpatient MRSA management, meaning they can be given orally? And then a bonus question is, what are the side effects of doxy and rifampin? So pause your screen, right? This is a classic, just me showing you another vignette of classic brucellosis so you can get it into your head. I want you to think about, plus doxy, what are the 3 other antibiotics that can be given orally for MRSA management outpatient? And then what are some side effects of doxy and rifampin? So pause your screen, think about it. So my 4 PO MRSA antibiotics are doxy, clindamycin, linezolid. Linezolid can be given oral or IV, and then TMP SMX. Okay. Remember, when I think about IV treatment, we can think about things like Vanco, daptomycin, and ceftaroline can also be considered. Okay. These are really high yield to know for your internal medicine rotation and for exams. Let's talk about side effects. So what are some side effects in this doxyrifampin brucellosis therapy? GI upset is going to be a big one. Skin rash, the elevated liver enzymes from the medications themselves. Not only can brucellosis cause it, but so can the medications. Doxy can stain your teeth. Rifampin can cause bodily fluids to turn orangish. So think about your pee, sweat, tears can all turn orange. Less common but important, the photosensitivity for doxy, hypersensitivity reactions, and then rifampin is associated with a rare hepatotoxicity. Clinical considerations in clinical trials, discontinuation of doxy and rifampin was rare. It was less than 5%. No significant difference in adverse events compared to other brucellosis regimens. And then we monitor the LFTs, especially if we have prolonged therapy or pre-existing liver disease. So the bottom line is this combination doxy-rifampin is well tolerated with proper monitoring. All right, so that's all I have on brucellosis. Commonly tested zoonotic disease. One you're going to want to look out for when you're on the IM wards. If you're working in the emergency department, it's always really important to ask patients about travel history and food exposure and what they do for work, right? It can point us in the right direction for a diagnosis. It's often overlooked, but a really, really good clinician will always ask about it. All right, reach out if you have any questions. Let me know what next subject you want me to cover. Until next time.